Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to attempt to extend the concept of being exceptionally cautious of making assumptions about anatomy that you cannot directly observe based on area. So I'm going to look at the hip rotators on purpose. I'm specifically looking at blood flow of the hip rotators. I'm going to add in obturator externus. It is essentially an auxiliary or a secondary hip rotator. So you've got the primary hip rotator group and then the secondary hip rotator group. So I'm going to go through piriformis, both obturators, both gemellis, both gemellus muscles, I said piriformis already, the glute max and the quadratus femoris. Okay, I'm going to let you know the variations in blood flow or arterial blood supply that are noted in a fairly small amount of resources, just to show, and also these are easy to find resources, so you just do a standard internet search for the muscles themselves, and this variance will pop up if you take a look. Now, some of them are more variable than others. Some of them are really not variable at all. But just to show you how in a very small area, in and around the pelvis and the greater trochanter, or in that range between, let's just say the os coxae or the acetabulum of the hip or the pelvis, where all the pelvic bones merge and generate the socket for the ball and socket of the hip, however you like to term this. Anyways, so we're going to look at the muscles. I'll list them out. I'll tell you the variances in blood flow, the common arteries and the less common arteries, or the less common notation. So the piriformis, from 4 separate sources, the standard, or the stuff that you'll sort of see the most: inferior gluteal, superior gluteal, and internal pudendal. You will also see notation of the lateral sacral artery, and specifically the gemellar branches of the internal pudendal. So lateral sacral is a bit of an outlier. The internal pudendal is not an outlier, but the specific mention of the gemellar branches of the internal pudendal is a bit of an outlier. So we've got some variance there. We do have some stability in the inferior gluteal, superior gluteal, internal pudendal, but then we have some variance. So if you want to talk about the piriformis and you want to talk about its blood supply, just know that if you see this video and you want to have a high degree of confidence in what you claim is the blood supply, you better go scouring way more sources and do an analysis of the frequency with which certain vessels come up and certain vessels don't. And you need to figure that out, because that variation is going to tell you more accurately what level of confidence you should have that you know the blood supply. I'm going to tell you from 4 resources. It's not as stable as one would like in these written resources. So the next one we'll look at is obturator internus, from 5 resources, right? The consistent ones are the obturator artery and the internal pudendal artery. There is notation, less commonly, of the gemellar branches of the internal pudendal, the superior gluteal, the inferior gluteal, the gluteal arteries as a unit, and the pudendal arteries as a unit. So there's a good amount of variation here. Again, if you want to talk about the obturator internus and you somehow magically are able to separate the obturator internus from the piriformis and the gemelli muscles, then you want to talk about the arterial supply with a high degree of confidence. Subsequent to interfacing with this recording, your confidence should drop, right? And this is from 5 easily available resources. You don't want to spend a lot of money. You don't need fancy books. So now we talk about the quadratus femoris. There's 6 resources here. It is very standard, or the only 2 arteries that are mentioned is the inferior gluteal and the medial circumflex femoral. So that sounds like stability. However, I'm just going to shimmy so I can see the screen better that I'm looking at. First resource is both of them. Second resource is the inferior gluteal only. Why did I note it that way? The third one has the, what is going on? The third one has the inferior gluteal in the chart and the medial circumflex femoral in the text. So you have to go looking harder for that one, so it's not easy to find that. And then the final one has both. So you have essentially two that if you just look at them really quick, it's the inferior gluteal only. If you take a little bit of time, you can find the medial circumflex in one of them, and then two. So I was wrong. It's not six. Excuse me. It's not 6 resources. It's 4 resources. So I screwed that one up when I typed that out. But it's stable, but you can find the variation there. So some say both. Some say one. One says one, but the other is present if you go looking a little bit harder. To look at the gemellus superior, 5 resources, as long as I didn't screw that up. You've consistently got the inferior gluteal and the internal pudendal. Then you get the superior gluteal sometimes. I think it's one resource that literally says sometimes superior gluteal. So first resource says both the inferior gluteal and the internal pudendal. Second resource says the inferior gluteal and the internal pudendal, and sometimes the superior gluteal. Another one says inferior gluteal only. Another one, inferior gluteal only. Another one, inferior gluteal only. So the internal pudendal, while it is there, it's not as consistent as the inferior gluteal. So hopefully I said internal pudendal, less consistent than inferior gluteal. Inferior gluteal is always there. The internal pudendal, sometimes there. The superior gluteal, literally it says sometimes. So again, 5 resources, variance in the blood supply of the gemellus superior. So you could probably say with a high degree of confidence inferior gluteal, but you should know that depending on the resource, they're going to have more. And we look at the gluteus maximus. This one is stable, right? You're not going to, I don't know that you'll find the blood supply to the gluteus maximus anywhere being anything other than both the inferior gluteal and the superior gluteal, but it's possible, right? That's every resource that I've looked at. I've noted 5, but I haven't found it anything other than that in my general anatomical travels. Now we get to the one that's the secondary rotator, the obturator externus. So I've got 4 here. The consistent is the obturator artery and the medial circumflex femoral artery. And then sometimes specifically the anterior branch of the obturator. So the obturator is the stable one. The medial circumflex is less consistently there. So first resource is obturator only. Second resource is obturator and MCF. The third one, obturator and the medial circumflex femoral. The final one is specifically the anterior branch of the obturator and the medial circumflex femoral. So again, you have one in here that just says obturator artery. You have the rest of them saying obturator and medial circumflex femoral. Okay. This acts as another opportunity to build confidence in the argument that I make, that when you are attempting to make confident statements about anatomy you cannot directly observe, so anything deeper than the external environment of observation, aka the region that you're in, very prominent bony landmarks, and movements that are restricted, when you start talking about nerves, it gets a little bit more confusing. When you start talking about blood supply, especially arterial supply, a little bit more confusing. If you start talking about venous drainage, much more confusing. If you want to talk about anything specific with respect to, say, the nervo vasorum or the blood flow to nerves, rarely are you going to find it described in a standard anatomical resource. In specific research papers, you may find something, but you won't find it consistently because it's highly varied. If you want to talk about lymphatic flow or lymphatic drainage, it is exceptionally general and points to nodes, right? So you expect that there will be some density of lymph nodes in particular regions. Other than that, you're not going to find much because it's so variable. So the venous system and the lymphatic system are known to be highly variable. The venous system, there is a general roadmap, but expect it to be wild and wacky when you actually cut something open. The arterial supply should be reasonably stable. However, it is not as stable as is easy to buy and easy to believe. So This is another call, another opportunity to point to simple, easy to find anatomical resources that are free, as long as you have an internet connection. So it's not truly free. You have to have enough consistent money to get yourself an internet connection somehow, or access the ability to actually get somewhere where you can have what is putatively a free internet connection. But you can find this information. It's not terribly hard to find. It's accessible. The arterial supply is known to be relatively stable throughout the body. However, it is commonly variable enough that within, what is this? 1, 2, 3, 4, 5, 6, 7 muscles, there's normal variation between the arterial supply to these muscles, depending on the specific resource that you use. So when you're learning anatomy, to learn anatomy, you're going to work off usually a common resource that that particular department happens to use. The moment you go outside of a single resource, you're going to find variation. If you're actually doing cadaver dissection, it is entirely likely that the instructors will make it clear that there are normal variations. Not always, but it's in all likelihood they'll be more honest about the variation. If you're using some form of I don't want to call it 3D because it's not 3D, but the anatomy apps that allow it to, it's 2D that appears 3D-ish. So you've got something on a tablet or something on a screen, and you can rotate and zoom in and zoom out and look at different angles of varying structures. Those are stabilized, normalized anatomical resources that will not give you appropriate acknowledgement of variation. So if you learn anatomy from an app, and you think you know anatomy, you know the anatomy that is contained within that app and nothing more. If you think you know anatomy from Netters, you know the anatomy that is contained within Netters and nothing more. Netters is an atlas, so it's really the pictures. Those pictures will often have, picture-in-picture windows, so little windows that show normal variation in particular areas. If you have Gray's Anatomy, so you've got pictures and words, and you think you know anatomy because of Gray's Anatomy, while it is updated regularly, you only know what's in there, okay? The problem with any resource is that it in it and of itself is a limit because it only has the information it has. It doesn't have the information it doesn't have. So if you're worried about accuracy with anatomy, especially when you're working as a hands-on practitioner, you're worried about the wrong thing. You should be worried about paying attention to the person who's in front of you and how they express in ways that you can observe and interact with. The ways you can observe is movement. The things you can interact with is movement. Whether it is the squish of a soft tissue or the yield to pressure of a soft tissue, or the gross movement of a joint, or the gross movement of a set of joints in series, aka macro motion, what I would call macro motion generally. That is more accurate than remembering anything in a damn textbook. The textbook will give you a normalized understanding of what should be in the region, especially if you're looking at it on a larger scale, a more macro scale, or a more gross scale. You'll sort of know what's there. You can start to understand what things are likely dangerous based on that anatomical roadmap. Acknowledge that any resource that you like is limited by itself because it is only presenting the information that it has. It is not presenting all available information. And all available information isn't presenting all available possibilities. So getting really nitpicky about anatomical structures and acting as if they make you a better clinician when you're a hands-on practitioner is unfortunately less accurate than one would like. You need to know anatomy. You need to have that understanding so that you know where danger is. You have some level of possible interpretation, especially to point to danger to others that can examine it on a deeper level, whether it be with image or surgery or what have you. If you're a hands-on practitioner, you're not accurate about anatomy. You're not going to be. You're limited by the fact that you're outside that person, that you can only observe them on that level. and you are limited by the resources that you have encoded and remembered. So just be cautious. Also, as a general clinical note, the vast majority of practitioners are likely to tell you that they don't remember their anatomy as accurately as they once did. More likely than that, they are going to tell you that they probably don't think about anatomy much. I have the experience of people that are not osteopathic practitioners telling me that osteopathic practitioners have the best anatomy or the best anatomy knowledge. And because I happen to know about the normal variation between resources about the same piece of anatomy, regardless of which one you look at, obviously say we look at this list, glute max, very stable with blood supply, but the other one's less stable with blood supply. Somebody tells me as a non-osteopathic practitioner that osteopathic practitioners have amazing anatomy knowledge, I'm going to laugh in their face. The osteopathic practitioners probably present or are observed as having high confidence in their anatomical knowledge, but they're not as accurate as they could be if they had images of the particular individual. And depending on the specific thing that might be going wrong, you have to know the different types of images to find that actual thing. So be cautious. Don't over-index on your anatomy knowledge because it may not match up with the individual that's in front of you the way you think it does. You need to know your anatomy. It's important, but don't allow it to increase your confidence above and beyond just the level of your ability to detect what type of danger might be there and what you might be able to name it so somebody else could explore it better than you. So thank you for listening this far. Hopefully you've learned something. We'll talk again soon.